All right, well, I think we are at the top of the hour. So I will go ahead and start the latest here IAS-USA dialogue. Today, Dr. Del Rio and I will talk to you about the latest on COVID-19 meets HIV, variants, vaccines, health disparities, and other fast evolving issues. I'm Wendy Armstrong. I'm a professor of medicine at Emory University. And I will let Dr. Del Rio introduce himself, and then I'll make a few announcements.
Yeah, I'm very glad to be here, Wendy. This is Carlos Del Rio. I'm professor of medicine here at Emory University, and I'm also a member of the board of the IAS-USA, and very excited to be in one of these conversations.
Yeah, so this is a reprise for us. We've done this before, but before we start, I do want to remind the audience to go ahead and use the question and answer button to ask questions. We will plan to have a dialogue for about 40 minutes, and then we will turn to the audience questions that hopefully we have answered some of them through the course of the dialogue. I'll let you know that chat has been disabled, and the dialogue is not available for CME, but will be available as a web and podcast after the live broadcast. We will also include the disclaimer, which is really important in these times, that that COVID-19 information rapidly can become out of date. And so we will tell you what we think we know now, but I can't guarantee that we will know the same thing tomorrow. But thanks to everyone so much for joining. I think, Carlos, one of the questions that was most prevalent before in the questions that were submitted before we started was really trying to understand the relationship between COVID-19 disease and HIV infection. And so I think that that's been a really evolving issue that's been fascinating to me over the course of these last many months. Do you want to tell us a little bit about that?
Yeah, I mean, I think all of us who take care of HIV patients and started seeing COVID, we said this is going to sort of produce havoc in our HIV patients. They're immunosuppressed. They have a lot of risk factors. They're a lot of same populations. African Americans, poor individuals. We're going to see a lot of patients with HIV and COVID in the hospital. And the reality is, I think most of us were surprised that indeed was not necessarily the case, even though, as you know from your clinic, many of our patients were getting infected. And I think we initially got one impression, and then we started to understand a little more. So, I mean, I think at this point in time, what I feel is that this is a very complex issue. You have, yes, probably immune suppression, probably a low CD4 count, increases your risk of complications, increases your risk of death. But it is also the other determinants that are driving a lot of the risk. And teasing those things out has been incredibly difficult.
Yeah, I totally agree. I will say, that this is one of the areas where I was wrong initially, that at first in our very large clinic that which for the audience is really has a high percentage of late stage HIV patients, we weren't seeing a lot of severe disease. And I think many of us talked about the possibility that HIV-associated immunosuppression may prevent some of the inflammatory response that was driving disease. And I think that's an area where I think we've had to dial back substantially. And I think the data is getting a little more clear, but there are so many questions. It does look like the prevalence of disease or the hit rate is not necessarily different than matched controls that have the similar, living situation and comorbidities. So doesn't look at that patients who are living with HIV have a greater risk of contracting COVID. But certainly it is, like you said, starting to look like there is an increased risk of severe outcomes. But what's driving that? And we know that may be comorbidities, which are highly prevalent in patients with HIV. There's data that shows that the risk of having comorbidities is greater in those with HIV than in those without. Is it an increased propensity towards inflammation? We know that there's increased inflammation in many patients with HIV. Is it the immune suppression and worse outcomes in folks with lower CD4 counts? It's a fascinating area, and I don't see that we're going to tease that out and be able to say that HIV infection alone is an independent risk factor. Do you?
No, I really don't think HIV infection alone is an independent risk factor. It is not HIV, the virus, but I think is the person living with HIV that because of a series of circumstances, that person is therefore at increased risk, but it's not necessarily just the virus. And again, as you know, some of the, we saw initial studies coming from, I guess, initially from Spain, from Italy, then our own study here in Atlanta and New York had some studies initially from sort of single institution studies or city studies that didn't seem that big. And then we started to see cohort studies, and I think studies from London, studies from South Africa, studies from New York are painting a little bit of a different picture. But again, talking about increased risk of complications, increased risk of death, but it may be in large part driven by all those other factors. And again, it just emphasizes that our patients with HIV do have, we know this for a while, the NCDs, the non-communicable diseases that we see in patients with HIV of, those of us doing HIV, a lot of times it's not managing the HIV anymore, but it's managing the obesity, diabetes, hypertension that the patients have. And that may be a lot of what's driving a lot of the excess mortality and excess risk of complications. So it's really, again, emphasizing the part that, you don't treat, you treat the patient, right? It's the entire patient that you need to think about.
Yeah, so I think the take home is exactly that I don't think we're going to completely tease this apart, but patients who are living with HIV do appear to be at increased risk of potentially severe disease, whether it is for any of those reasons we've discussed. So I think that's the take home. And to me, that reinforces the notion that I think this should be included as one of the chronic diseases that increase risk of severe outcomes and therefore should be in a higher phase of COVID vaccination.
No, I totally agree with you. There's still a lot of states are still having discussions of who is included in their 1B. And I think we need to be very clear that, HIV has to be one of those categories, simply because, again, may not be just the HIV, but is who is impacted by HIV in our country. We should not forget that it is primarily, individuals living in poverty, it's primarily people living in crowded conditions, primarily, people living in comorbidities that we're talking about. So it's the individual with HIV that's high risk. And because of that condition, they should be in the high risk category. And, I think we have clinics, like yours and others that would be ideal settings to provide vaccination to patients and would really be, you have done a great job in your clinic of, doing testing, doing infusion of monoclonal antibodies, and doing all those others. You fit into comprehensive care, all those other things, and I think adding vaccines makes a lot of sense. And in fact, in our health system, you're beginning to be one of the first ones to start, one of the first clinics that started vaccination.
I think this is an area, though, where anybody listening is interested in advocacy. Like, as you said, the states, to some extent, there are recommendations from the CDC and ACIP about what high-risk populations are, and I think HIV needs to be moved into one of the ones that clearly is associated with increased risk. But then I think we need to advocate at the state level to be sure that our patients are included in earlier rollout in phase 1B. But you're right, we have started vaccinating, and we've started vaccinating the over 65 patients in our clinics that are meeting that criteria. And, and that's been a really interesting experience that we can talk more about. But I think we also need to look at models where we vaccinate not only in clinics, but in the community as well.
In the community, right. And then the other issue, I think, is, I've been surprised looking at the data. Maybe you want to mention a little bit. You've been doing a lot of testing in the clinic. The percentage of patients that have evidence, have been infected, right? I mean, you have a large, positivity rate, a very high positivity rate in your patients. Again, emphasizing that it is their living conditions, it is who they are that puts them at very high risk of being infected.
Yeah, no, there's no question. And our positivity rates have been extremely high. I think there may be, I think one factor at play is certainly that it's a high risk population, but I also think that it speaks a little bit to health systems and the fact that our patients are very comfortable with the clinic and comfortable coming into the clinic to get tested. And I think many in the Black and brown communities that are not living with HIV don't have that very comfortable place to go. And so I think we probably also get a greater proportion of our sick patients in to get tested compared to those who don't have a resource like this. And I think that's a problem.
You know, but it also speaks about the importance of trust, right?
Mm-hmm.
Like in HIV, in COVID, if you got trust in the healthcare system, you're going to get tested, you're going to get vaccinated, you're going to do all those other things. But at the core of this is really trust. And I think one of the things that we need to leverage, and we have continued, and I hope we can leverage more in addressing COVID, is actually the Ryan White and the clinics and the trust that we've built in many of those clinics that actually allows, you know, we don't need to invent a new trust system. We know how that works. We know how to work with community, et cetera, and how to make that work.
No, I agree. And I think one place where that comes out in spades is when we think about vaccine hesitancy. The trust has been so important. And, you know, when we look at vaccinating, and we can talk about vaccination in people living with HIV, but then convincing people to be vaccinated is, you know, it's a one-on-one experience. It's a longitudinal series of conversations that starts before vaccines actually available and explores people's fears and concerns and anxieties and again, I think we're lucky to have the clinic space to do that, but that's a conversation that needs to get out into the community further as well.
And it's in a way no different than the conversation you have when you have a newly diagnosed individual and you're talking about starting antiretroviral therapy.
No, that's absolutely right. I think, go ahead.
Yeah, so I was going to ask you also about, you know, you have done some, and I've gotten some questions about this. You've done some monoclonal antibody infusions in the clinic, and, you know, I got asked a couple of times, is there any reason why not to do this in patients with HIV? And I couldn't find anything, but have you read anything related to monoclonal antibodies in patients with HIV?
No, I definitely support using monoclonal antibodies in HIV. Again, we have a very, very high rate of comorbidities in our clinic. And again, feel that our patients are at increased risk of severe outcomes just on the potentially on the basis of their HIV alone. And so we have infused a number of patients with really no negative results. And you know, again, because we're focused on our population, so it's a smaller population, we've been able to do so relatively quickly and get people infused in a window that is consistent with where the most benefit may be. But no, I don't think there are any contraindications in those living with HIV.
No, I agree. And I want to use also this opportunity to just, again, you know, remind people and give a shout out to the Active 2 and the study, because again, it was HIV investigators like David Wall and others who really put this together. And I think it's because we feel that this is a population where you really can use this monoclonal antibodies early on to prevent them from getting sick because they're at a high risk of complications.
You know, I think talking about vaccines a little bit, you know, like I said, that's been an ongoing conversation. We've had a lot of questions from our population living with HIV about the safety and then the efficacy of vaccines in this population. You've been you've been an investigator in some of the studies. What have you seen with safety? Have you seen?
Well, you know, as far as safety is concerned, the few HIV infected individuals, people living with HIV who participated in vaccine studies, and again, remember, the Pfizer study didn't have many, then the Moderna study allowed people with HIV, with control HIV. They seem to be doing okay. What really rocked a lot of us, and I think we can talk a little bit more, is when we had just a couple of days ago, you know, the results from the Moderna, from the Novavax study in South Africa, and talking about how the vaccine didn't perform that well in people with HIV. And I think it's worth having a discussion because I think the data there is skewed significantly by a small number of patients. And maybe you want to say something about it.
Sure. I actually, I'm glad you brought that up because I think it is very skewed. I think when you look at the numbers overall, you know, the reports are in the South African context of 60% efficacy, but that's reduced to, you know, under 50% if you include 60% efficacy in those who are HIV negative, but reduced to 50% efficacy if you include both HIV positive and HIV negative individuals. And if you actually dissect the numbers, it's actually, I think, very clear that the answer is still out. Because there were only, in those living with HIV, there were 76 patients in the Novavax arm and 72 in the placebo arm. There were 4 infections in the Novavax arm and only 2 in the placebo arm. So those numbers are riding on nearly equal, numbers in each arm, with only absolute difference of 2 in the number of infections. And that is way too small to be making sweeping generalizations about the efficacy of this vaccine in the population of individuals living with HIV. So I think that is at the moment too soon to say.
And I think it also emphasizes the danger of subgroup analysis in a study, because again, you can get into really wrong conclusions when you do subgroup analysis, because the study wasn't powered to look at the impact of the vaccine in people with HIV. This was a sub-analysis they did afterwards, and you're absolutely right. And that's why the confidence intervals are so big. But it's very unfortunate that the media really capture this, and it's in the press release and it's everywhere, right? And I think it really throws a wrench into those of us working with HIV and the people living with HIV, saying, oh, is this vaccine not going to be effective in me? And my experience from what I can tell so far is there appears to be absolutely no difference whether you have HIV or not, at least with the vaccines we have available in this country right now.
Yeah, well, so fortunately, and that was after a lot of advocacy by a lot of groups, and I'm really grateful that so many people mobilized around this, that there have been individuals who are living with HIV in all of the trials. And so while I haven't seen many of the subgroup analyses from the others yet, again, there's been no signal raised otherwise. And so I think we need to wait and see the full data set. But again, I'm so encouraged that there are enrolled patients so that we can hope to get a little bit more data. But we, again, probably need to increase those numbers because they're all relatively small.
So let's go into a little bit of a data-free zone, but maybe I would love to hear your thoughts on this. Other vaccines that we use in persons living with HIV, we wait for, you diagnose somebody with a CD4 count of 50, we wait for them to be suppressed, we then wait for them to get immunologically reconstituted, and many vaccines are, recommended after somebody gets above 200 CD4 cells. We don't have any recommendation like that around our COVID vaccines, but what would you do? I mean, what would be your thought? And again, this is data-free, we're just having a discussion.
Yeah, so yes, with the caveat data-free, to me, I would treat this like a flu shot right now. We have an ongoing pandemic. And so while I don't know if someone would respond better after, let's say, in a patient without viral suppression, I suspect someone might respond better if they have viral suppression. In the midst of an ongoing pandemic, I'm just not sure that I would wait, and I would treat it like a flu shot. And if I have an arm in front of me that is willing to take a vaccine, I would like to give it.
I totally agree with you, and I feel the same way. And that's why we started talking about the high rates we're seeing in our patients, et cetera. Even if you get some protection, it's better than no protection. And I agree with you. I think once we have, once we expand to the 1B group, and if HIV persons living with HIV are included in the 1B, we should just go ahead and when we diagnose people, literally make that, as you say, as a flu shot, a priority. We may find differently, but again, it will be a good study subject, but something that I wouldn't wait, honestly.
And I think one thing that's, we have obsessed a lot, I think, as a nation and as a people about these subtle differences in efficacy between all of the vaccines. But the bottom line is all of them are looking pretty good against severe disease, where we, at least excluding what we don't know about the South African variant right now, but they're looking pretty good. And if I can, take my patient who lives in a congregate setting from, having efficacy against severe disease, but perhaps not against mild or moderate disease, I'll take that in a second.
And even the data from South Africa and the South African variant looks really good against severe disease and mortality. It doesn't look that good for mild to moderate disease, but it's still, it prevents you from getting very ill. I think it's a good vaccine.
Yeah, although I think with the caveat that the AstraZeneca trial didn't enroll very many people at high risk of progression. So I think there's some nerves about if they had a population that was at risk of severe disease.
Correct.
I think with an asterisk.
Correct. Correct. So, so how can we use what we're learning? I mean, we have had discussions in our country, I think, for the longest I can remember, about social determinants of health. And we have heard, we've been at meetings, we've heard presentations, we've done it ourselves, quite frankly, talking about, the driver of the disease here is poverty, is housing, is transportation, lack of transportation. But we really, I don't think as a nation have done anything seriously to really do and confront social determinants of health. And I see COVID as an opportunity to once and for all really begin to address this. What you had the opportunity to say something to the Biden administration, Dr. Marcela Nunez, who's in charge of equity, what would you say we need to do?
Well, thanks for such an easy question, Carl. I'm going to sidestep a little bit and say I'm just so grateful that this is turning a spotlight onto social determinants of health, and it's a spotlight that is sorely needed. Obviously, we're turning that spotlight now in the midst of COVID-19, but we need to keep that spotlight trained on so many health issues, but including, of course, the HIV, which is near and dear to my heart. But, and I think there's a lot we need to do to understand what we can do. These are all tricky problems. Clearly, housing, for example, is critical. And I think we need to challenge ourselves and our governments to develop more housing options and so on. But I mean, I think this gives us an incredible opportunity to also think about how we reach people and what their access is to healthcare. And I think that's an easier nut to crack sometimes than some of those others. And, I believe that we need to tear down our notions that all medical activity needs to occur in brick and mortar clinics. That as we develop new strategies to really vaccinate the population at risk, and I think we must, I would ask the Biden administration to, as I think they plan to really require states to make efforts to think about addressing disparities in vaccine administration. If that's then getting out into community settings, into FQHCs, into community grocery stores or community pharmacies to administer vaccine and have sort of one-on-one conversations with champions, that's a model that can be exploited and used for other health issues as well. I mean, think about if we then can use that model for testing or for blood pressure, taking blood pressure control, or developing pop-up clinics, or really, if we can learn how to go to where the people are instead of make the people come to us, which then brings in transportation issues and stigma issues and all kinds of other things, I think we can be so much more successful. And so to me, it's about encouraging creative solutions and using this vaccination campaign to then learn strategies that we can use for clinical care.
Well, I agree. And the reason I asked the tough question is because probably maybe you saw it, maybe you didn't, but today the Biden administration equity task force members were announced. And I was very pleased to see Dr. James Hildreth as one of the members. And, Dr. Hildreth is the president of Meharry College School of Medicine, but he also is going to be a little plug for Croy. In a couple of weeks, we're going to have him as a plenary speaker at Croy, and he's going to talk about equity and he's going to talk about disparities. And I really think with James, we really have the HIV community really has a strong advocate in that community, and I think he's going to be asking for advice and what things to do. And I think we can really use the COVID focus that the equity team is having to really address issues impacting our HIV persons living with HIV. And I think it's a huge opportunity to have him in there. He understands HIV, he cares about HIV, and he's one of us. So I think I'm really happy to see him in that task force.
No, that's awesome.
So the issue of one issue that comes up is trials, right? And as you said, a lot of work has been done in the by the advocacy community to have persons living with HIV included in trials, but only the trials, the vaccine trials right now, only including people with control HIV. And it would be nice to have some data on people who have a low CD4 count or don't have control HIV. The persons you and I were talking about, and maybe it's not going to be a phase 3 trial, but maybe it will be a phase 4 trial. It may be an opportunity to actually get either CFARS or NIH or others to fund, or industry even, to fund studies in those populations that maybe we as providers and as clinic investigators can potentially get some funding to look at that. Because I think those are going to be, it's a little bit like the pregnant woman issue, they weren't included in clinical trials, but the questions come up, the population's still there and you have to address the questions. Vaccine go ahead.
And as I say, and I think one of the original concerns about including those living with HIV without viral suppression was safety. And again, I don't think that with most of these vaccine products that safety is an issue, is a real concern for me. Even in someone with a low CD4 count. And I think
I think it's going to be like a flu shot. The worst thing that's going to happen is it's not going to produce antibodies, right? It's not going to, right. It's not going to, it's the efficacy that I worry about, but not the safety.
Yeah, no. And but I think I get asked that quite a lot by others. If we think the vaccine is safe in patients living with HIV, is there a concern with an mRNA vaccine in someone with reverse transcriptase? Could it become DNA and therefore incorporate into the genome? And the answer is no, that's all of that is in different compartments in the cell, nucleus and non-nucleus and so on. I think there are concerns that really haven't been borne out in any way that should restrict pursuing those kinds of additional studies at this point.
So it's interesting that you bring that up, because I was actually asked yesterday that question about, should I get an mRNA vaccine because I'm taking a reverse transcriptase inhibitor and that's going to inhibit the mRNA to produce what it's supposed to do? And I said, no, it doesn't do that. But people tend to get confused, and I think we need to clarify those issues. That you don't need to stop your antiretrovirals if you're getting vaccinated. You're totally fine, and continue taking them.
And again, for our, so I'll make another plug for something I've been involved in, which is for our providers on the call. HIV-MA has a really terrific fact sheet on their website. If you just Google HIV-MA COVID vaccine, for providers to answer questions like this that may come from patients. It's written at a provider level, but it answers questions that patients may raise about vaccines in patients with HIV. And so that's a resource, I think, for those of us who are who are administering vaccines to our population.
That's great. That's a wonderful resource, and glad you mentioned it, because it's really nicely done. There's 1.2 million persons living with HIV in our country. What strategies, what messages, how do we ensure that we get to them, and how would you make sure that we can develop get them vaccinated?
Yeah, I think it's a similar strategy probably to the whole rest of the country. I don't think people living with HIV are unique necessarily in needing a different sort of outreach, but I do think because there are so many that come from Black and brown communities, or so many where trust is an issue with the medical system. And then I think probably there are additional or unique layers of concern based on having HIV. I think it requires champions in clinics, and it's going to require champions on the ground in communities. And I think those two things are both key. I think the trust of the provider, clinician, patient relationship is a huge benefit. And I've had numerous conversations with patients who have been very nervous about the vaccine. And again, it's being very open. It is not dismissing fears and anxieties that are real. It's sometimes, being willing to start a conversation and then continue it at the next visit. But I think, again, I can't think of the number of times someone has said to me, I trust you, doc. If you tell me it's okay, I'm going to do it. And so I think we as physicians and clinicians need to leverage that and do that. But I think we need to leverage community members, community advocates in the HIV community, very, very powerful, important voices to get the message out. Very knowledgeable and terrific advocates. So it's going to take all sorts of levels of people, I think, to ensure that we get our whole U.S. population vaccinated, including our population of individuals living with HIV.
I agree with you, but I think one advantage that we do have in the HIV community is that we have an organized community. We have an advocacy, we have, HIVMA, we have Ryan White clinics. So I think, going back to this whole issue of advocacy, I think getting together and really advocating at the federal and state level to ensure that that person living with HIV are in the 1B priority, I think is one thing that we can do very effectively. And we are an organized community, and this is a community that has fought for many things from the beginning. And I think this is just another fight to get. And don't wait for somebody to write you into the priorities. Just use your advocacy to explain why you need to be in the priorities. And I think creating those messages of why HIV, persons living with HIV need to be in the priority, I think is going to be really important as we communicate with public health leaders. And
so many people have asked about variants, and I think that again underscores the need for us to try and move this as quickly as we can. This is a push and a conversation because we need to get viral transmission down in this country in order to decrease the risk that at least the South African and Brazilian variants don't have the opportunity to take hold in the same way. I think the cat is out of the bag with the B117 variant originally described in Britain.
Yeah, no, absolutely. And I think, the issue of variants is something that just continues to worry me. And I think we have in this race between vaccinating, controlling transmission, because again, we know from HIV that viruses that are not reproducing, are not transmitting, are not mutating, and therefore don't become resistant. So if we can, transmission and mutations occur when RNA viruses are replicating. And if they're transmitting, that's when they're mutating. So I really worry that we know in HIV that we need to bring the COVID viral load, community viral load down significantly.
As I say, we have some lessons in HIV that we have learned the hard way and can translate those, I think, in other ways.
So today you probably saw the MMWR that came out of face masking. So are you going to do anything differently yourself or in the clinic? Are you going to recommend double masking? Are you recommend an extra mask? What are your thoughts about all this data that came out?
So I'm going to go into my data-free zone again. I think I think that again, a surgical level or a cloth mask can be very effective. But what I think is probably the lesson from that MMWR and the lesson that I think we've learned in other ways is that what's really important is fit and multi-layer. And so what hasn't been, what the MMWR, talks about double masking with pictures of a poorly fitting surgical mask and a thin cloth mask over it, which essentially gives you a fit and double layer and multi-layer. I think that's what we need is fit and multi-layer. I think there are cloth masks that fit very tightly that are fit and multi-layer, and I would love to see those studied because I suspect that they're quite effective as compared to just the single ply with the ear loops that are a little bit baggy, at least on my face. And so I'm not going to do anything different because I have a cloth mask that is fit and multi-layer that I use in the community, and I have a surgical mask that I've got knotted for a good fit that I use in the clinic, and I reserve use of an N95 when I am seeing a critically ill known COVID patient.
I am 100% in agreement with you. I think the most important thing is that we all wear a mask, that we wear it correctly, and that it fits appropriately in our face, and a multi-layer mask, as you mentioned. But it's not totally data free. I mean, we've seen in our hospitals, in our clinics, since we have mask enforcement in our clinics, and it wasn't a double mask, the infections in healthcare workers went dramatically down. It's not like the data is very clear. So I feel comfortable wearing a well-fit mask, and I don't feel the need to give everybody an N95, even though some people are saying, oh, we need the best mask possible. We need a mask, period. We need a good mask, and everybody needs to be wearing a good mask.
Yeah, no, we need everybody to wear a mask. And surgical masks, I think, are very effective. Yeah, if we can accomplish getting a greater percentage of individuals in the United States wearing a mask in public places outside the house, I would be thrilled. And I think we would see huge revenues from that.
So we were, very pleased, of course, to see, CDC come with a mandate for masking in transportation. But we need, and there's some nice data that just came out from, Peter Rivera and others showing that states that have mask mandates, had lower, increase in cases early on than those that did not. So again, emphasizing that this at the community level actually makes a difference. So it's not so much about, the double mask or whatever, it's about the masking and get everybody masking, I think is critically important. And I think that's the important thing to remind our patients, right? And to tell our friends in our community about the importance of masking and telling people how to wear a mask, because again, if you don't wear it appropriately, it's not going to work.
No, that's right. And I think increasing hysteria about everybody trying to use an N95 that is, honestly, I find them quite suffocating over the long period of time, and that are scarce and that we need in our hospitals, and that I just don't think they're necessary. I think and if that decreases mask use because folks are uncomfortable, then we've really actually harmed our efforts. We just need people to mask.
So many patients are asking questions about vaccines. Have you, in your interactions, those one-on-one interactions, been able to change some minds?
Oh, I think absolutely. And I think the key, again, as I mentioned, is you're sort of being open-minded. So, the questions, people are legitimately afraid. And often it is it's been misinformation. And so, for example, a friend of mine mentioned that, she had a patient who was terrified of getting COVID and lived with a son who was at increased risk, and felt certain and wanted them both to be vaccinated at the same time, even though she was a healthcare worker and could get vaccinated earlier. And the reason was that she felt that getting febrile after vaccine must mean that she could transmit COVID to her child. And so it was a protection of her child that was leading her to delay, instead of realizing that that would protect her child for her, the healthcare worker, to be vaccinated. So it's, again, very patiently listening and openly listening to the stories and understanding the motivation and what the fear is. It's explaining what Operation Warp Speed meant, that it was an infusion of money, but it wasn't cut corners on vaccine trials. Explaining, how many people have gone through the trials and how we have watched people for enough months to have a sense of what side effects may be present. I think explaining things in a dispassionate way, acknowledging fear and anxiety, and really delving into what is motivating people to be hesitant makes a huge difference. And we've changed a lot of minds. But I also think, and you and I have talked about this, that when somebody says, okay, doc, I think I'm comfortable with this, I'd like to do it, you want to have vaccine there and ready if you can, because it's then going home and somebody else saying, you shouldn't be getting that vaccine, that changes minds in the wrong direction.
Yeah, I think that's the biggest challenge I'm having right now is you talk to people and they say, okay, I want to get the vaccine. And then you try to get them a vaccine appointment and there's not one open. It really is a huge missed opportunity. You almost feel like, I feel like I struck out, quite frankly, and I hope that, when we get better vaccine availability, that's going to change. So you've been vaccinated, I've been vaccinated. I frequently also talk to people about my experience, right? And very clear. And I said, I had pain in my arm, but it wasn't terrible. I had, 2 days afterwards, I was feeling, the next day I felt maybe a little down, but then I was fine. And it was certainly less severe than getting, it was kind of similar to a flu shot, maybe a little more pain, was much less severe than getting Shingrix, and not something that a little Tylenol or Advil didn't take care of. How about your experience?
Yeah, I'm in that camp of people who wish that I'd had a little bit more response because I'd feel better that I was having the appropriate immune response. But to validate, I also have colleagues who've gotten really really quite miserable with this for a few days. But again, and it's again acknowledging that that can happen, but that outcome, which we know is going to be limited, is a much less bad outcome than getting severe COVID. And severe COVID, all of us have seen, can affect the young, healthy person that you wouldn't expect to be at increased risk, as well as it can affect the older person who you would expect to be at increased risk. And so, so I think that's the framing is, I can't, if I tell somebody, I didn't feel bad at all, then when they feel bad, then it actually discredits me a little bit. So I think,
I mean, I think you tell them what you had, but you also tell about the spectrum, right?
yeah, exactly.
But I think, the one thing I remind people is that, we've had 30 million persons infected with COVID in our country and close to 500,000 deaths. And we've had, now close to 40 million people vaccinated and no deaths. So, I mean, it's the evidence is also clear that this makes a huge difference and it's a very effective vaccine. One of the things that I get asked a lot, what do you tell patients about taking Tylenol? Or anti-inflammatories? Do you tell them to pre-medicate? You don't? What do you do?
I personally don't tell them to pre-medicate for a couple of reasons. One is that the symptoms that you're going to get are likely to be beyond the half-life of that Tylenol anyway. And then if there's any risk that would decrease your immune responsiveness initially, I wouldn't want to take that risk. But what do you say?
Yeah, same thing. I just tell them, get some Tylenol and if you need it after you get the vaccine and you get pain, take it. But otherwise, there's no point in pre-medicating or post-medicating because you don't know. You may be one like you or me that had very mild symptoms. I mean, I literally had a little pain that, I took extra strength Tylenol once because of the pain and I was fine the next day. And by the second vaccine, I didn't even take that. So there's no point on pre-medicating. It really doesn't make any sense to take a medicine that is not going to make much of a difference. So the other issue that comes up is, you said it at the beginning. How do we, COVID is changing it's advancing every. How do you keep up with the literature? What do we do?
I think that's really challenging, and I think I'm grateful for conversations like this from other experts in areas I don't keep up on as well. For example, and for others who synthesize the literature, because there's too much for any individual to keep up on. Do you have great resources that you've been using?
I think combination of things. People that tell me about things. Looking at Twitter and looking at some trusted sources, and people like Paul Sachs and others, and then with the caveat that we're both in the editorial board, but I like reading Journal Watch. I think we've done a good job in Journal Watch in summarizing literature, the COVID literature, and making, I was very pleased that New England Journal of Medicine made that open access. So all those summaries are open access, and it's just something that I still think that those summaries are very relevant, because there's like trying to drink from a fire hydrant. There's no way to keep up with everything that is happening.
So, Carlos, one of the questions I see in the Q&A is, have you changed your behavior since you had the vaccine? That's
a good question. I haven't changed my behavior, but I am a little more relaxed in the sense that, I got the other day on the elevator at Grady, and when there were 4 people on the elevator, I didn't at the next floor get off the elevator. I felt that I was, I continued going up the elevator, which pre-vaccination, I would have gotten off the elevator the moment there were more than 4 people on the elevator. I just was very uncomfortable getting in an elevator crowd of people. I didn't think the elevator was crowded, but 3 plus me was my limit. Now I was able to make it up to 6. So I think there's a little sense of being a little more relaxed, but that doesn't mean that I have relaxed my mask wearing, my social distancing, and all the other things that I think I did from the beginning, that have kept me so far uninfected despite being in the wards and seeing patients and other things that I think, and again, is not because I think I was pretty obsessive about the wearing of a mask and my eye protection and all those other things, but I'm a little more relaxed. I think that's the major difference. I sleep better.
I'll say I get every other day questions from my over 80-year-old parents about when they can eat at a restaurant or with their friends again. And it's painful to tell them that I'm just not prepared for them to do that yet. They are now fully vaccinated and are waiting out their 2 weeks from their last vaccine. And I guess I haven't changed. I have not been in a restaurant and have not changed my behavior in that way either. Although I think, and I think it requires seeing the rates come down in this country and seeing what the story is going to be with the variants before I will feel comfortable relaxing more what I do. Although I agree that there is a weight off my shoulders.
You know, it's interesting that you mentioned that because Josh Weiss from Georgia Tech has put together this little application, this little web page where you can actually look if you have 10 people in a room, depending on what the local transmission is, what the chances are of having somebody with COVID there. And at the last when the epidemic, the way it was happening last Sunday at the Super Bowl, in many cities, if you had a Super Bowl party of 25 people, it was a 30 to 40% chance that there was at least one person with COVID at that Super Bowl party. So, no, enough reasons not to go. But if you were able to bring the transmission down to somewhere between 5, 10 or 5 per 100, then all of a sudden that number drops significantly. Then you can have, 25 people and the number of people, with COVID is 1 or less. So I think the community transmission, the amount of virus in the community makes a huge difference into what you'll be able to do and what you won't be able to do. Yeah. I still think that close environments with poor ventilation, and by that I mean bars, it's a place that I'm not ready to go anytime soon.
Agreed. I think we need to hold on tight for a bit longer, and that's what I've been telling my parents. Although I've told them they can maybe eat 6 feet apart from one set of friends who's also fully vaccinated in their bubble.
So that's a good question. Since we're talking about that, I agree with you. I would tell them if they have a set of friends that's been vaccinated, you put in 2 different parts of the table, 6 feet apart, and that's fine. How about a question that I get asked all the time is, if somebody's infected and the other person is infected in the household, can they isolate together? Should they be separate? What are you telling patients? What are you telling people about that?
I actually haven't been asked that before, but I guess that I don't see a reason why they can't isolate together. We don't, it's not that we would expect that they have different variants or that's going to change, an individual course in that way. And if they're both definitely infected, is there something I'm missing?
No, I think you're absolutely right. But I mean, this is an issue that comes up again, talking about housing, right? I mean, there may be a family that has a 2-bedroom house, and what you want to do is try to limit the transmission as much as possible around the household. And, if 2 individuals are infected, but 2 aren't, try to get those 2 individuals isolated in the same room, but try to keep the others from not getting infected, because it's going to be really important. And it doesn't mean that every single, infected individual needs to be isolated, because at some point in time, again, in households, it becomes really complicated. And I really worry household transmission is really what is driving a lot of the transmission. Is the multi-generational housing is not enough, living space that is driving a lot of transmission in Black and brown communities, because, there's not enough space to isolate. And I think as a country, I'm really sad we've never done anything about that. In many other places, if you don't have where to isolate, they'll find you a place to isolate. And we did not do that in our country. And I think that created a lot of transmission in households that should have never happened.
No, I totally agree. And I think that's a truly important point. I was looking at the Q&A given the time, and one question that's come up quite a lot is how, are there recommendations for how to advocate for increasing the priority for those living with HIV on the vaccination scheme? And I know you're very active with state and local government. Would love to hear your thoughts. I would say one thing before letting you jump in, though, with probably more learned ideas. is that there is an ACIP committee meeting coming up in a week or two, I think.
Yeah.
It is very easy to make a public comment, and you can go to the website, ACIP Vaccine COVID, and you can either just submit a written comment and advocate for exactly this, very simply, or you can actually apply to make a public comment and have, I think it's 3 minutes that you're allowed to make a public comment. That's one setting, I think, that can be very, very helpful. If there is an overrun of written comments on one topic, I think that's very impactful. And so, so that's one clear opportunity. But I think there also needs to be state and regional level advocacy. And what would you recommend in that way?
Well, you and I have talked a lot about advocacy being an incredible tool in what we do in HIV and how it has made a big difference in many other things. I think you just call, you just, write, you call, you send an email to your local representative, to your representative in Congress, to you call, you send an email to your director of public health in your state, but you let them know what are the reasons that, this is not just because, oh, I want my population to be prioritized, because as one of the public health, director of public health in the state said to me the other day, everybody wants to be a priority. And the question is, how do you make priorities? And I think we have evidence from HIV of higher risk, higher comorbidities, worse outcomes. Use that data, frame it in that respect, and say, this is why this population needs to be a priority. And I think we emphasize that, we're going to get farther than just saying, me too, me too, me too, which is what a lot of people are saying. And again, I worry that, it's always who has the loudest voice. And I would say, the HIV community has had a loud voice. Let's use it.
No, absolutely. And I see one comment, and I'm guessing that you're asking references that show poor COVID outcomes with HIV, with patients with HIV to advocate for vaccine priority. If you're asking where the references are, I can guide you to, I think, actually a commentary that is freely available to the public that actually summarizes that data really beautifully. And that is, if you were to Google Gandhi and Triant, Triant and Gandhi, Raj Gandhi and Jean Triant from MGH wrote a terrific editorial in CID that really, again, summarized what we know up to last month or this month, that includes all those references and would be a great resource to make a public comment.
Yeah, and I think you just, again, you put it together, you didn't talk much about social media, but use social media, use Twitter, tag your representative, say why. But I think the evidence in that paper is really good, and you can actually use that in a very effective way. So as you think about where we're going to be, in the next few months, do you sort of let's play the crystal ball, better, worse, variants, we're coming down, our cases are coming down, our hospitalizations are coming down. We got to keep that, but I worry about the variants. So where do you see things, and what's your concern?
Yeah, I think clearly the B117, the variant initially recognized in the UK that I want to avoid assigning a country name to, is in this country, and clearly it is evolving rapidly. But I also think, on the more hopeful side, that the vaccines that are rolling out have good activity against it. And so to me, it's a race. The next few months are a race between that variant and our vaccination rate. And if we can continue to vaccinate rapidly, I hope that we won't see what's been seen in Israel, where although they, with vaccine to the older population, brought down hospitalizations quite effectively, the number of cases has risen because younger folks haven't been vaccinated, and that variant has really taken hold, and as you've heard and read, is more transmissible. So to me, the next few months are about that variant. And then the longer run is, can we get rates down and prevent the South African variant? And there I did again with the country, but with the other variants that are more resistant to the vaccine effects, can we keep them at bay?
So a question that comes up all the time, and is, we'll have data, I hope, soon about whether this vaccines prevent not only severe disease, but actually transmission. What is your gut feeling on that?
My gut is that they prevent transmission probably fairly well, but we haven't seen the data yet, and I don't know that for sure. Sure, maybe it's just hopeful, but I think that they will severely dent transmission. I hope.
I feel the same way. I think they're going to show that they significantly decrease acquisition and therefore decrease transmission. And if that's the case, then I would challenge that we need to rethink our vaccination strategy. You saw probably that paper in Science recently saying that 20 to 49 years old are the ones that are sort of, driving the epidemic in our country. And what you said in Israel is young people. And you almost think about, okay, maybe we should vaccinate those 20 to 49 years old, because in fact, especially now that, if the FDA gives an EUA to the Johnson & Johnson vaccine, a single shot vaccine, maybe that's the population we ought to get the vaccine to, and quickly try to see if we can bring down rates of transmission in the younger population. Again, I just think that many of those are also at high risk of HIV. That's the population that, we have been struggling for many years trying to get them in PrEP and other prevention interventions.
But it's the same old problem, right? If you're young and healthy, you don't access healthcare.
You're invincible.
You're invincible. Healthcare is expensive, too expensive. And so if you're young and healthy, preventive medicine is not prioritized, particularly in this country that doesn't incentivize it. So yeah, that is again the nugget that's in our favor for our patients living with HIV is that they are in healthcare systems and are coming to see us on a regular basis, and therefore are in some respects a little bit of a captive audience. That is not true for those that are not living with HIV and don't have chronic diseases that require follow-up.
So are you seeing an increase again in HIV testing rates? Speaking about that, because we saw for a while just a significant drop in the amount of HIV testing that was happening.
Yeah, I think it is going to take time for us to get back on course. I think I'm heartened by the shift in clinics to be both flexible with telemedicine, which I think has really great advantages and some disadvantages as well. And so I don't think is the panacea for all things, but I'm heartened in care that I think most clinics are back to speed in some way or another. I think we are catching up a little bit on STI testing, where we've had shortages as well as less in clinic traffic. But I think we're still behind the 8 ball there. I think we're still behind on HIV testing. I'm hopeful that PrEP will start to pick back up, again, using tele and other kinds of avenues. But I think the testing avenues are going to take a minute. I think we've probably set back the end the epidemic a bit.
Yeah, I'm really worried about that. And I'm just hoping that we don't set up the end the epidemic too much and that we keep our eye on the ball, that at the end of the day, what we need to focus, COVID is an emergency right now, but HIV is when COVID is gone, HIV is still going to be here, and we need to address the HIV epidemic. And I think as HIV providers, part of our advocacy has to be also remind people that HIV is still here, and we cannot just become, the COVID country.
And not only that, but what we need to do is grab again some of these really fantastic things that have happened, the silver lining of COVID, which not only is telemedicine, but things like decreased bureaucracy in other ways and more flexibility with prescriptions and mailing prescriptions and being Ryan White certified and doing that by mail or by fax. And we need to grab some of these flexibilities that got into the system with COVID and keep them. And I think that's really, really important because, like you said, HIV will outlast COVID. That is one crystal ball I'm pretty sure of.
Yeah. Well, I've really enjoyed our conversation, and I hope people also enjoyed it. I think we have a lot to learn, and I think we have a lot to contribute. And I think, again, HIV clinicians have been at the forefront of HIV researchers have been at the forefront of doing a lot of the research around COVID. And I think we have a lot to contribute going forward to ending the COVID epidemic, but keep that energy to also continue ending the HIV epidemic, not forget that part.
No, absolutely. Couldn't agree more. Underscore times 12.
Okay, well, I want to wish everybody, well, thank everybody for listening. If wherever you are, good evening or good afternoon, and thank you for listening. And look forward to having you join us for the upcoming dialogues. There are a couple coming up. You can see the upcoming dialogues are available at the IAS-USA website, www.iasusa.org, and look forward to hearing from you again.
All right. Thank you so much, everybody, for joining.